Good morning, students. Today we have Professor Sudhir Kumar with us. We'll be talking about a case of avascular necrosis of hip. This is a common long case which is given to you in your practical examination. So Professor Sudhir Kumar will share with us his pearls of wisdom. Good morning, sir.
Very good morning, Dr. Harpreet.
So this is a common case which a student is presented with. And usually at the end of his history taking, he's asked to summarize his salient points of history. So how do you suggest the students should go about presenting his salient points of history?
Yeah, in fact, the positive history is important as well as certain negative points. So to start with, the patient in fact presents to you with an insidious onset of pain. And he may just tell you that he started with a morning stiffness, which possibly over the period of time as the sun rises, as the day rises, the pain gets eased out. Then he starts telling you about stiffness in the pain, stiffness in the hip. And this stiffness and the pain, it slowly progresses over a period of time. And then he also will tell you that his walking distance gradually diminishes and he gets tired on his hip very easily. At the same time, the patient initially may not have pain in the hip joint, and he may just tell you that he is experiencing pain in the knee, while as such, when he's sitting around comfortably sitting on a chair, he doesn't have any pain on the knee at all, but he can move his knee all right. So that should raise a suspicion that his hip is involved. While describing the history, certain very events or the personal habits must be taken into account. Like, is there any history of alcohol intake? Alcohol intake, regular alcohol intake is the most important aspect. Young people may be on steroid and they take anabolic steroids for developing or making their muscles look stronger or bulky. So they could have at times they could have renal problem, or they may be suffering from diabetes. This is the history points that should be elicited upon. And of course, there are certain other negative history that you should ask for, that has there been any history of trauma preceding this pain, and has there been any prolonged history of fever or constitutional symptoms like loss of weight, night pains, or having a contact with a tubercular patient, or in fact involvement of any other joint, or stiffness in multiple joint should also be taken into consideration while eliciting the history in these patients.
So important to take the negative history as well, just not the positive history, just not the positive complaints the patient is talking about, also the negative history, because you want to rule out other differential diagnosis. So coming to differential diagnosis, sir, at the end of his history, what all differential diagnosis should the student tell to the examiner?
After having collected the subjective complaints of your patient, a data is being raised. Based on that data, you should suspect, is your patient having a avascular necrosis of the hip, which is like having coronary on a femoral head. And very rarely in our country you come across primary osteoarthrosis. But primary osteoarthrosis in a young man is very highly unlikely. very highly unlikely in our country. Particularly, the tuberculosis of the hip joint is the one which is endemic in many places in our country. So that must be kept as a differential diagnosis. While in females, are transient osteoporosis of the hip in females is the one which normally resolve over a period of time. However, a secondary osteoarthritis of the hip joint, which occurs in middle-age group, in old healed Perthes disease, or dysplasia of the hip, or if the patient had fractured neck of femur in early childhood. These are the differential diagnoses that should be kept in mind. However, monoarticular rheumatoid of a bigger joint is a highly unlikely situation in our part of the country.
So in history, we keeping these as differential diagnosis, but while taking our history, we need to remember we have to take out history points so that we can also ruling out these differentials. So as you said, age is an important criteria. This osteonecrosis would be a young person, whereas a primary osteoarthritis would be more common in a elderly. Also, a past history of some problems in the childhood, like a Perthes or DDH, they have to be taken.
Or slipped capitofemoral epiphysis. These are all sequelae of the sequelae of the septic arthritis of the hip joint. They need to be kept in mind also, but your history would be able to negate these findings.
So important, take a good history. This is a long case. You have to be meticulous and comprehensive in your history taking. So when the examinee is presenting his positive findings on the examination, what all things he should talk about, which are the salient findings he should present to the examiner?
The patient will have endalgic gait, which is classically found in these patients. There could be also short limb gait. So there could be also combination of these two. And so one should be very careful in assessing these patients and make them walk for a little while and observe them from front as well as from the side. And the affected hip will have a flexion deformity, and most of the time they may not have any fixed deformity of abduction or adduction. There may be a jog of movement available to you in these directions. So similarly in rotations, rotation may be may be restricted. In external rotation may be restricted, and internal rotation may be available to you to a little more degree than the external rotation in extension, and there will be a shortening, true shortening in these patients depending on what stage they present to you. A very important feature that you have in these patients would be a sectorial sign, a sign in which you find that there is a differential rotation in extension and flexion. So depending on which part of the head of the femur is involved to start with. Mostly it is the supralateral part. So in supralateral part you find that when you flex the hip joint, as you flex the hip joint and you're nearing to the 90 degree, it goes outward, suggesting you that this is an axis deviation and there is a differential involvement of the femoral head.
So two important findings in these patients, as sir mentioned, would be axis deviation. As you flex the hip, the knee goes into external rotation, goes towards the same side shoulder, and a sectorial sign, which is differential rotations in hip extension and flexion. So these would be important findings. Don't miss them, and you may be asked to demonstrate them. Just be meticulous with your demonstrations. So we already talked about the sectoral sign. Sometimes such patients present to us with bilateral hip involvement. So this becomes very tricky to demonstrate. If there is a bilateral hip disease, the flexion deformity demonstration becomes a bit tricky for the examinee. So how do you suggest he should go about it? Is it wiser to do a Thomas's test only?
Well, you see, normally we give a unilateral hip to our candidates in examination, because that is a test of examination. However, you get many a times bilateral involvement of the femoral head. So if you have to examine, then you must examine the opposite hip as well to find out that the opposite hip is absolutely normal. In case you suspect that opposite hip also has a deformity or restriction of movement, you should be performing a flexion deformity, which could be demonstrated on a patient by bringing the patient to the end edge of the couch and the patient to be made prone so that the trunk and the head lies on the couch and the limbs are hanging free at the edge of the couch. Both the limbs are hanging free at the edge of the couch. That will take care of the excessive lumbar lordosis. Then extend both the hip joint, and where it stops getting extended is the flexion deformity in either hip. So this is what we call as a stele prone test, which need to be done in these patients to demonstrate flexion deformity, fixed flexion deformity in bilateral hip joints.
So remember, as sir beautifully just explained this test, you will be asked to tell about this test in case the patient has a bilateral hip disease. Usually, as sir said, it's a norm to keep a unilateral hip disease, but sometimes bilateral hip disease patient may also be given to you in the examination. So at the end of the examination, does our differential change, or we'll keep the same differentials as at the end of the history? Sir.
At the end of your examination, you see, you are more or less sure that that your patient is suffering from a secondary osteoarthritis of the hip joint, and probably the cause is osteonecrosis, because in infective hip, you will find global restriction of movements. And in osteonecrosis, you may find movements will be present in almost all direction to a larger degree.
So you'll say that your diagnosis is a secondary osteoarthritis with the etiology most probably as osteonecrosis. Should he go about saying like that?
Yes. So far as the history contributes along with it, and other inflammatory conditions can be excluded out from the history. However, the differential diagnosis still remains in the same order.
Okay. So a common question asked to the examinee is that why do you keep your osteonecrosis as your first differential? And so what answer should he give to the examiner? What do you expect him to be saying? That how has he excluded other causes? Or why is his first differential as osteonecrosis?
Insidious onset with slow progression, inhibiting his daily activities, like most commonly the floor activities for which they are particularly used to, and without having any constitutional symptoms of evening rise of temperature, loss of weight, fever, and no other joint is involved. There is no other joint involvement with any deformity, and no contact with a tuberculous patient. And there has been no significant history of trauma. So these characteristic findings will lead him to suggest that your patient probably has osteonecrosis. And in addition, if he has any intake of steroid, that becomes a positive factor.
So, history suggesting hip disease with negative history regarding tuberculosis or inflammatory joint disease, and positive history of maybe a steroid or alcohol intake. All these go in favor of a osteonecrosis. So you have to spell out all these points.
And I think you should also mention that patient is not a chronic smoker.
Okay.
Even in chronic smokers, also this can result in the avascular necrosis of the femoral head.
So next, usually the question is, how will you confirm your diagnosis?
One should say about taking X-ray of pelvis, including both hip joints, in identical position, AP view, and the lateral view of the involved hip. You have the lateral view of the other hip as well, just to compare.
So lateral view of again both hips too, so that we can compare both AP and lateral views. So at this stage, usually the X-ray is put in the examination, and the examinee is asked to read the X-ray. And so various stages are described in avascular necrosis of hip. So can you elaborate what all stages and what is seen on an X-ray on these stages?
You see, the typical staging that we use is Fiket and Arlet, which gives a very good information onto a well taken bronchiogram. So in stage 1, when the patient present to you with just pain or stiffness in the hip joint, X-rays appear more or less normal. If the X-rays have been taken very carefully and a well digitalized X-ray has been done and digitalized being produced, you will find that the affected hip has an osteoporosis to start with. It may just show you an osteoporosis in particular part of the head of the femur, but otherwise to the normal eyes it absolutely looks normal. The X-ray may be absolutely normal, but in the initial stage you have in fact osteoporosis, which is because there is a avascular necrosis and the cells do not receive the blood supply, so it immediately undergoes saponification. So it produces edema, and that results in relative osteoporosis as there is a hyperemia from the surrounding area. There will be hyperemia from the surrounding area, and that will give you osteoporosis. And if you go on to the next stage, which is stage 2, and in the stage 2, what you find is a segment well defined where there may be just a sclerosis, and there will be a zone of osteoporosis, because by this time that avascularity to that segment of the head has already been determined, and the body processes, there will be in body processes there is hyperemia to take away that debris. So there is underlying zone of osteoporosis, and of course, as the stage advances, you can see the zone of osteoporosis, and there will be that very segment dips down, producing a crescent sign, and that is stage 3. There will be some incongruity of the head. That means the head starts getting incongruous because the articular cartilage starts getting depressed. There is fragmentation.
So you said incongruous femoral head and some fragmentation. So stage 3, the joint per se still is looks okay, joint space.
Well, the joint space does get diminished as there is, and there is an irregularity. What happens is there is irregularity, but acetabulum by and large appears to be normal, and there may be some sclerosis seen right on the eyebrow of the acetabulum.
The sorsal sign.
And that's right. That's you call it sorsal sign. And some subluxation may also be visible supralaterally. However, there is no degenerative change that you have found by this time in the acetabulum, other than the sclerosis at the top of the acetabulum. And the fragmentation further keeps on going, and the head becomes avascular. There are degenerative changes which result in the head contour being lost. So head, instead of remaining spherical, becomes spheroidal, which we classically call as a spheroidal head. And the changes take place in the femoral head. There is a collapse, fragmentation, diminution of the joint space, and there may also be an associated subluxation. If the disease goes advanced stage, in the initial stage of FICAD 4, there may not be a subluxation, but as the disease progresses, the acetabular also gets affected, and you find there is a break in the Shenton line. So there is a subluxation, as if the head is riding onto the acetabulum.
So as sir beautifully spelled out that in stage 4 there will be superior migration because of the joint collapse, and there is a break in Shenton's line. So sir beautifully spelled out what are all the stages. So remember these stages. You'll be asked about these all stages in your examination, definitely, if you get a question.
And there are cystic changes, metaphyseal cystic changes as well develop. Multiple cysts, which we classically call as, geoids, appear in the various planes. So that's typical of secondary osteoarthrosis of the hip joint.
So at the end of these theoretical question, next question comes to the examinee is that what will be your aim of treatment in such a patient? So how should the student tell what is his aim of treatment in such a patient?
You see, one must remember that when we are discussing about the treatment, uh, the hip is got three aspects, three requirements. One is it should remain painless, it should remain mobile and stable. So painless, stable, mobile. You see, to give all the three parameters which is expected by the patient may not be possible at what stage the patient presents to you. Let's say if the patient is presenting to you in stage 1, so you have to relieve his pain. The hip is relatively mobile, it's stable. So how do you relieve his pain? You relieve his pain by giving him rest to the part and protect the hip for a while, which may not be possible into day-to-day life because these patients are well mobile. It's said that 20 to 30% of these hips do become normal.
And talking about stage 1?
Stage 1. They do resolve. Alendronate has been the drug of choice in these patients, which has been tried over a period of time. But there is no definite evidence available of using alendronate in these patients. However, supportive therapy can be given to these patients, and if they resolve in 4 to 6 weeks time, well and good. Otherwise they go into stage 2. In stage 2, again the treatment remains either a core decompression, if the patient can understand about it, because with the core decompression you can also do a biopsy on these patients, and it gives an adequate form of revascularization by stimulating granulation tissue, which possibly revascularize it. So if there is any evidence, it's by doing a core decompression, which has effect either by giving let's say venous pressure release, as well as promoting revascularization. Now they after let's say doing a core decompression, you give a non-weight bearing to your patient for a period of 6 to 8 weeks. Now if a patient presents to you in stage 3, now stage 3, already in the early stage the collapse has yet not taken place. There is a definite area of sclerosis, and there is a zone for osteoporosis. So you can revascularize possibly the head by doing a core decompression and then using a vascularized bone graft or a muscle pedicle bone graft. It has been observed that if a vascularized bone graft is given, quite a number of patients, say roughly around 20% of them, do form a salvageable hip. There has been studies on muscle pedicle bone graft, either a tensor fascia lata bone graft or a quadratus femoris bone graft, which have also given a sufficiently workable hip to these younger people for quite a long time. So these procedures are all buying out time and helping your patient to live on his own femoral head and his own hip joint for an active period of his life. However, when a patient comes to you in stage 4, you have a very little choice other than to do a total hip replacement. In nutshell, that remains the broad aspect of principle of treatment in these patients.
So, as sir spelled out that the hip requirements are painless, stability, and mobility. But depending upon the stage of the disease, you plan your treatment. But aim would be to provide most of these 3 requirements to the hip. So, disease staging we have already talked about. We use the Fickett-Arlett staging. That is the most common staging that you should know by heart. Anything else, sir? Fickett-Arlett should be good enough.
To my mind, it is good enough, but there are some people who are interested in knowing about Steinberg classification also, but most practical remains the Fickett-Arlett.
So you should know this Fickett-Arlett by heart. Even if someone wakes you up from sleep, you should be able to spell it out. And Steinberg, if for others, you should remember this also, but these 2 should suffice. How will you plan your treatment? We already talked about this. It depends upon the stage of the disease. So if it's later stages, you're planning to do a replacement. In earlier stagings, you're trying to preserve or salvage the head. Sir, in today's era, in today's world, is there any role of any non-replacement arthroplasty or osteotomies in today's world? The femoral head looks quite diseased, quite bad. Any role of any other excision arthroplasty or something else?
You see, however, osteotomies, the proximal femoral osteotomies, have been done particularly for stage 3, in which they try to do a osteotomy for rotating the head, so that you bring the better head into weight bearing area, and that has in the hands of certain authors like René Martin has done it, and he has shown that the hip could remain viable for a period of 15 years or so. So that could be done, in which you need to have 3-dimensional picture of the femoral head to find out which part of the head is suitable for bringing under the weight-bearing area. However, if your patient comes to you in a stage 4, the stage 4 is a difficult one, in which if you the nearest possible is painless, mobile, stable is your total hip replacement. However, if a patient has a unilateral involvement and he says, no, I'm a floor worker, most of my activities are done on the floor, and I am not an office goer, or I am not an executive, and I don't want total hip replacement. You suggest him. After all, you have to counsel your patients before you start a treatment. Now he says, no, I am not interested in total hip replacement. I don't want it. So you have an alternative for him. You tell him, okay, we'll do excision arthroplasty for you. So you will remain relatively mobile, relatively pain-free, and relatively stable. More or less it will become more or less stable in certain activities. While sitting is okay, while performing floor activities is okay, but if he has to walk for a long distance or even for a short distance, he'll limp on it, he'll lurch on it. So depends on the requirement of your patient and how he takes it up.
So in public hospitals where the examination usually takes place, you usually get people from rural areas who are doing farming and sitting on the floor and doing such activities. So can the patient, then the student go ahead and say that he will do THR in such patients? Is it a right answer to say in the examination? Because some examiners are a bit that THR would be a bit not so good for such patients.
You're absolutely right. You see, we have to look at the economical condition of our patient and the social requirement of our patient. We have to educate our patient for a procedure that we are doing. It is entirely the responsibility of the treating surgeon to open the book in front of him and tell him that this is what you are going to get, this is what you are going to lose. How far can we help you? Let him choose. They are all wise people according to their requirement. Now the surgeon can go further, say, okay, you do not want a total hip replacement because you are relatively younger and you have many more years to go, and this hip, of course, I can give you for maximum 20 years. You may have to go for another operation at that stage. So if you want, we can do a excision arthroplasty for you. If you still feel that you are unstable, you can add on to a pelvic support osteotomy to a patient, and they are able to go for a very long time, and they can work with it. And to my mind, the surgeon can be very, very emphatic and say, in younger patient, it may be a very short-sighted option when a monoarticular hip is involved to do a total hip replacement. So he has an option. He can give a excision arthroplasty, do a pelvic support osteotomy, and patient may become relatively stable, the hip becomes relatively stable, painless. He doesn't have to undergo the second operation. If the limb is relatively short, he can always give him a shoe raise on it, and the hip remains functional.
So I think the student should say that I'll talk to the patient and I'll keep all the options before him and let him decide what is best for him. Is that the way to go about it?
Yeah, and if a person is a laborer, he says, no, I have to be strong enough to, then he has to go for orthodesis. But again, because avascular necrosis particularly, you never know, the other hip may be involved later. Because if there are, you see, there could be precipitating factor in these patients. So it has to be considered in totality. So no procedure is an end procedure for that patient. He has to be educated, counseled, and the treating surgeon must be well educated about the pros and cons of each procedure.
Very well said, sir. No procedure is an end procedure in such patients because they are very young. Sir, any salient points if that patient comes in a early stage? Usually the student says he'll do core decompression. So what all points, if he has asked to tell about what do you do or how do you do a core decompression, what are the steps he must mention? What are the important points he must mention?
By doing a core decompression, first thing is that you must assess your patient fully, and you should find out that the patient doesn't have a comorbid condition, and you must warn him if he has been alcohol taker or a cigarette smoker or a tobacco chewer. they all should be taken into consideration, and the patient must be willing to abstain from all these vices. And then when you've decided to do a core decompression, it is important that you should take a MR of your patient as well as you do a CT scan. Must identify the area which is sclerosed. The segment must be identified. You have to go under that segment of sclerosis, and you should have an imaging device with you. We say, well, if you have three-dimensional pictures available, that's good enough. But every operating theater doesn't have a CT scan. So image identifier is the one. So in the anteroposterior view and the lateral view, we must reach to the segment which to be decompressed. And the core decompression is performed by putting your guide wire at the proper site, and then using a core needle on your drill, and whatever material comes out, you can also send it for histopathological examination, and that could tell you about trabecular necrosis. And once the core decompression is done, the patient must remain non-weight bearing for a period of at least 8 weeks.
So there are certain prerequisites. Identify the sclerosed segment pre-operatively, using MRI and CT scan. Reach the segment of sclerosis, check it on AP and lateral views using a guide wire, and then core out that area and send it for biopsy. Important, patient has to be non-weight bearing for at least 8 weeks. Sir, any role, or what is the role of a fibular graft in such patients? Do you advise for it or not advise for it? What's your say in it?
You see, we are talking about pure decompression. We are not talking about giving support to that area. Of course, if vascularized bone grafting is, if it is to be, that is separate thing. Vascularized bone grafting or a muscle pedicle bone grafting is the one which is going to give vascularization to the femoral head. So whole idea is to give vascularization. Now, core decompression is meant for opening up the channels, and if we are further wanting to extend this procedure, because core decompression is a minimally invasive procedure.
Yes.
While if we are aiming at providing definite blood supply to the femoral head by additional means, then we'll have to give a vascularized bone graft, which has an evidence, which has definite evidence, and other procedure like putting in just a fibular stud. I have my own doubts whether it will improve onto the blood supply.
Just as a structural support, any avascular piece of bone, as fibula? Because some authors do recommend it. There's literature saying that people doing that also, just to provide structural support during the initial 6-8 weeks when there's non-weight bearing. So I know it's controversial, so I think the student should refrain from talking about these controversial things?
No. He should not refrain, but he should keep it in mind. He should know it because this has been going on in our country. Right.
Yes.
So, if somebody is interested to know about it, yes, sir, it has been described that this may provide some structural support.
So I think the better way to go about is that yes, it is described in the literature, but maybe it's not followed in our institution. Can you say that?
You don't have to say that it's not followed in our institution and all that. I don't think so. It is important.
Okay.
It is not important. Important is to understand the underlying biological responses that is important and what we are trying to achieve ultimately. Student must know evidence-based practices. And so far as available till date on an evidence, core decompression has been worldwide used and it has a definite stimulation for opening up vascular channel so that there is stimulation for revascularization and there is a decompression. One. So far as vascularized bone graft is concerned, it has a good evidence. But just putting a wide fibula, you can put anything that you want, right? Of course, fibula is its own biological structure, so it has been used. And nature has given you fibula to be used in various places. But it has been observed that fibula remains fibula even in adults, even at a later stage, wherever you put it up. It doesn't get incorporated. Maybe only the ends may get little incorporated, but it remains, the whole structure remains as such. Because you know it for incorporation, if you go into a biological concept, then the incorporation of a bone graft that we use, it first undergoes osteolysis.
Yes.
And then the bone gets deposited on it. And then it starts getting remodeled.
It acts as a scaffold, actually.
It's just as a scaffold. So, I think it's important for the students of orthopedics to understand that we use biological concept. We use evidence-based concept. So, I have amply emphasized on this point, and that is why Fickett classification is important, because it is giving you prognosis as well as a guideline for treatment, broad guidelines for treatment, and what is expected out of a femoral head. However, no procedure, I said, is an end procedure in avascular necrosis. We are looking for biological procedures in these situations, whether stem cell phenomena can work, which has not given any evidence, whether platelet-rich plasmas are being used, and you see, this has not yet given us any evidence. So we would finally look for a biological reconstruction of the femoral head, then
we may have an end procedure. Okay. Sir, thank you. It was a very detailed, comprehensive pearls of wisdom from you. Any ending words you'd like to say for the students if he comes across a case like this in the exam?
I think you must examine the opposite hip. It's very important. Very important, because many a times you get bilateral problem in avascular necrosis of femoral head. And you should understand about the axis deviation in these patients. And also remember the X-ray pictures that you are expected, because before an X-ray is put to you, the examiner may ask you, what do you expect to see in the X-ray? So if you have the clear idea of the stages of Ficket, you will be able to spell them out. So hence it's very important for you to know the various stages expected out in the X-rays, and that will also lead you to finally to your treatment. Thank you.
Thank you. Just be confident about your history, your exam findings, and your theory. This is an important case. Prepare for it well. Thank you, sir. Thank you, students.